This film is intended for eye surgeons for training and education purposes. Viewer discretion is strongly recommended.
Hello friends, I'm here with one of the most challenging case maybe in the last few months. An 80-year-old man who presents with the phacoemulsific glaucoma, the pressures are high, pupil is non-dilating because of pseudoexfoliation, and the antechamber looks to be uniformly shallow, and it looks like the entire lens iris diaphragm is shifted forward and pushing on the iris, and that's the reason why we're having an angle closure glaucoma in this patient. So needless to say, the lens would be quite bulky. Now, after controlling the pressure with medicines, the case is posted for surgery. And let me pause here, and I would like all of you to take a pen and paper and write down what are the thoughts which are going into your mind. How are you going to plan surgery in this patient? What difficulties are you anticipating, and how do you plan to tackle it? So I'm assuming that you have all written down, and let me go through the thoughts which are running in my head. So there are multiple complexities. We have got a shallow anterior chamber, a rigid pupil, a compromised capsular bag. I'm expecting loose zonules. And apart from that, we have got a very mature cataract to deal with. And I'm not sure how easy the access would be. And how do we ascertain long-term stability of the lens when we have a generalized zonulopathy? So these are the points which are going into my head. To take care of each of this issue, I am having a game plan. Now for the pupil, I'm going to use a pupil expansion device, and before that I would like to stretch the pupil and then place a device, because this pupil is too small and it might be challenging to fix the device itself. What device am I going to use in this case? Because I would want to have a bigger pupil expansion, I would go ahead with a Gupta ring. And to take care of these zonules, I'm going to use the CTR first, and then if it's not good enough, I'm going to use the capsular hooks. Okay, now what would be the timing of the CTR insertion? Well, I would like to go ahead and insert the CTR for two reasons. Number one, it's going to give me an equatorial 360-degree support to the bag before even I start the nucleus management, and that's going to improve the safety. Number two, it might also decrease the chance of a fluid misdirection happening and a positive pressure developing, because as we all know, in eyes with pseudoexfoliation, the zonular barrier is very weak and there is every chance of the fluid to percolate across the zonules into the Berger space and then result in a fluid misdirection like syndrome. So that would be another hypothesis. That's what I would like to use a CTR. What size would I want to use a CTR? The biometry suggests that this is an average sized eye, so I'm going to use a 11 to 13 mm CTR. And if the bag is still not strong enough, I'm going to have my capsule hooks ready to use them in case the bag is not stable enough before I begin my emulsification process. And finally, for the long-term stability of the lens, I would be using the IOL trap technique to secure the lens. That is, the haptics of the multi-piece hydrophobic acrylic lens will be in the sulcus with the optic pushed back to achieve the optic capture. So this is my plan, and let us see whether I can implement these plans correctly for this case. The two side ports are made. Before doing a stretch pupilloplasty, I would like to stain the capsule, simply because for stretching the pupil you need OVD inside the eye, and once OVD is put, staining of the capsule becomes difficult. That's the reason why I'm going to stain the capsule before stretching the pupil. There's another challenge when trying to stain the capsule. I want to stain the peripheral part of the anterior capsule, which is hidden by the iris. So to address that, I'm going inside or behind the iris and injecting a couple of drops of trypan blue. Mind you, I can't inject more simply because there is a chance that the trypan blue can run across the zonular barrier into the Berger space, and that itself can hinder visualization because of the absence of red glow. So I need to be very cautious while doing this step. So I presume that the capsular staining would be good enough. It is washed off, and now is the time to stretch the pupil. Since the pupil is very rigid, I would like to pre-stretch it. Pre-stretching has few advantages in this rigid pupil. It gives better dilatation when we fix the device, and it's also easier to fix the device onto the pupil when the pupil is already stretched. There is one distinct disadvantage when we're trying to manipulate this device. Now, the chamber is extremely shallow. The lens is swollen. We don't have very much space here. And because this expansion device is slightly bulky, it's biplanar, there's always a risk of, injuring the anticapsule when you're trying to manipulate this device onto the pupillary margin. So I have had few experiences in the past, so that was going back in my head. So we have to be very careful not to damage either the overlying corneal endothelium nor the underlying capsule. So I'm finding it difficult to engage the distal notch to the pupillary margin, which I usually achieve, but in this case I'm unable to orient it appropriately. But nevertheless, I just inject and drop this device on the iris, and unknowingly my right hand notch has engaged the pupil. I still need to fix these 3 notches onto the pupillary margin. So unlike the B-Hex device, which is very thin, this device is slightly bulkier, and a surgeon who is not used to this device might find it a little bit overwhelming. But the advantage is that it just gives bigger dilatation. That's one of the pros of it, and it also comes with few cons which we have to work around. Under the cover of the OVD, each of these notches are being fixed onto the pupil using a Sinskey hook. The ring is pulled inside the pupillary margin and then dropped in so that the notch goes and hooks the pupillary margin. Now this process is carefully repeated so that the remaining 2 notches are also engaged, and now we have a diamond-shaped expansion of the pupil with all the 4 notches engaging the pupillary margin. At this point, what is striking for me is some part of the anterior capsule is not stained with trypan blue at all. Now, staining of the capsule is extremely important in this eye simply because I need to have an appropriately sized rhexis so that I can achieve IOL trap. Apart from that, rhexis is probably the most critical step in this procedure, simply because if I get the rhexis right, I can put in the CTR, I can use hooks to stabilize the bag, and that's it. If to achieve all these things, I need to stain the capsule well. Now, I go in with my dye and try to stain the capsule. Mind you, at this stage, the chamber is already filled with a dispersive OVD. But I'm hoping that some amount of stain would be taken up by the capsule. But as I wash it off, unfortunately, I realize that not much of a stain is taken care of. So, realizing how important it is for me to stain the capsule, I go ahead with my irrigation cannula, wash off all the OVD which is there in the antechamber, and then try to re-stain the capsule. And thankfully, after my second attempt, there is some visible staining of the capsule, and this is going to be very helpful for me. So these are the small things which actually help you to implement your larger plans effectively. So if you want to put in a CT or hook the bag, you need to see the capsule well to perform the rhexis. So time to perform the rhexis now. This is a real challenge when we come to know the status of the zonules. I'm going in with my regular Capsulorhexis forceps, trying to pinch and perforate the anterior capsule. The moment I touch it, you can see the entire bag is moving around. There are plenty of wrinkles, and I am unsuccessful in perforating the capsule. Just demonstrate the amount of laxity which is there. So in such situations, the best instrument to go ahead and puncture the capsule is to use a 26G needle bent, which is super sharp. And go ahead and make a nick, and because it is so sharp, you are able to perforate the capsule, raise a flap. And before I grasp it with my forceps, I want to refill the chamber with OVD. The moment I fill the chamber with OVD, you can see the entire lens shifting, and I can in fact see the zonular insertions quite clearly on my left side. So the bag is wobbly, it moves to the left and the right. Now with the eye pressurized, I need to center my rhexis appropriately. In eyes with zonular weakness, I always prefer to use the forceps because it gives better control and is also easier to tear the capsule in the presence of the zonular laxity. I want to aim a rhexis about 5mm. I don't want a very small rhexis because if I have a very small rhexis, nucleus management is going to be difficult. On the contrary, if I have a very larger rhexis, I might not be successful in achieving an optic capture later on, which is essential to do the IOL trap technique. So I have my rhexis done now. It would be maybe marginally bigger than 5, maybe 5.5, and also maybe mildly eccentric. This is the moment which I would like to check whether the nucleus in the cortical mass is free from its attachment to the capsular bag. In most average cases who are having this intermittent mature cataracts, I would avoid a hydrodissection because usually the nucleus is mobile quite easily. However, in this patient, because of the severe generalized laxity, I want to go ahead and try hydrodissection, and just to ensure that the nucleus in the cortical mass is free from the capsular bag. So I wouldn't venture to do nucleus emulsification until I get this step right. So as I'm trying to decompress the bag and nudge the nucleus around, it's very evident that the entire bag is moving along with the nucleus. So it is quite difficult for me to separate the cortical nucleus mass from the capsule in spite of doing a hydrodissection. So if you don't have a countertraction from the zonules holding the bag, achieving hydrodissection also becomes challenging, and hence I'm unable to separate the corticocapsular adhesions. Now, how do you proceed at this stage? Well, the first step would be to stabilize the bag. Now, there are two options. Should I put in the CTR first, or should I hook the capsular bag first? So my preferred choice is always to insert the CTR early. As I've told before, the advantages much more supersede the potential side effect. A few of my colleagues and friends are concerned about introducing CTR early. The only phobia they have is what at the end of the surgery we may have a PC tear, then having a CTR in the bag would be a problem. Well, in some sense, their argument is right, but I would say that, if you have a CTR in the bag, it really enhances safety. And of course, we should be careful and try our best to prevent a PC tear from happening. But however, if it is inevitable and it does happen, it's fine. Sometimes it just stays in the sulcus. It's all right. So that is my argument. So my preference is always to go ahead and place it early. In this case, because of the profound zonular instability, along with the CTR, I'm going to introduce and hook the retake. I'm going to use the hooks as well to stabilize the bag. So I make these 4 side ports which are equidistant from each other. They are placed more posterior limbal with a shorter corneal tunnel so that navigating these hooks becomes much more easier. The hooks which I am using are made in India by Madhu Instruments. They do a good job, but definitely they are not as good as the MST ones, which have got a broader plate and they give much broader support to the bag. But unfortunately, I find them very expensive and most of my patients can't afford them. So that's the reason we use these Indian device, and it does a fairly good job for us. So as I'm introducing these hooks to engage the capsular margin, one important principle we need to understand here is that we should not overstretch the capsular bag. So when we do that, these capsules are not very healthy. They're friable. When you're trying to hook and try to tighten it, there's always a risk of tearing the capsule. And if that happens, then the game is over. So that's the reason why I would be very mindful in the amount of tightening I would perform, at least in the early phases. So now we have 4 hooks and a CTR stabilizing the bag, and this should be good enough. That's what I thought. Now, once I'm certain that the bag is stabilized, it's the time to move ahead and perform the nucleus management. The nucleus is around grade 3 plus, I suppose. So in this case, I'm going to do a direct chop technique. But before that, I'm going to create a small central pit as I do for most denser cataracts. This ensures me to bury my tip deep into the substance of the nucleus, grasp it, and then perform my vertical chops. I need to remind myself that my movements have to be as gentle as possible, because we are in a delicate situation. So another important tip I'd like to share here, when you're dealing with such an eye with profound zonular weakness, when you're trying to rotate the nucleus, it would be best to use both the instruments held at opposite end of the nucleus to rotate. This bimanual rotation would be much more effective in rotating the nucleus without causing any extra stress on the bag. So this bimanual rotation was definitely helpful in such eyes. The bag is extremely delicate. the chopper goes down vertically and very gentle lateral separation maneuvers are being done. So in these sort of cases, I think again, patience is the greatest virtue one can have. So be very gentle, very miserly with the movements. Eventually, I am broken down this nucleus into multiple smaller fragments. So as the nucleus fragments are being divided and very slow bimanual rotation of the fragments are being done, we need to observe that the bag is still wobbly and that is a cause for concern. So at this stage, my concentration is totally on the dividing these fragments. At this stage, the capsular hooks are still holding the capsular bag. So I feel I want to rotate the nucleus. I go back, I inject OVD into the antechamber in the capsular bag so that I firm up the eye, and this would help me to rotate the nucleus much more easily. Now, as I'm mobilizing the second epinucleus into my angle of attack, I realize that the entire bag is still moving along with the nucleus. Well, this is because the capsule hooks have disengaged. That's the reason why the bag is moving. So during this manipulation, the capsule hooks have just got disengaged from the capsular bag, and that's the reason why we are seeing this excessive movement of the capsular bag. Even with the hooks off, I thought let me try and emulsify these fragments. Well, as we can see, the bag is very wobbly and it would not be wiser to go ahead and emulsify it in such a state. So what should we do now? Well, the answer is simple. Go back and hook the bag again. Come out, inject OVD again and reposition each of these hooks so that they go in and engage the bag well. During the second attempt, I am stretching these hooks a little bit so that the bag is securely held and hopefully it would withstand the tension until the end of the surgery. Well, all these steps are going to take a lot of time, but as I told in my previous video, I think these are the cases where we should forget about looking at the clock. Instead, we should look at the calendar. So now with the bag being firmly anchored in by the 4 hooks, the time to emulsify these fragments. The first fragment is pulled out of the bag, and as I begin emulsifying, I can appreciate a sense of a lack of space, Everything looks to be very crowded. As I'm emulsifying, I think that I am more anterior than what I would usually like to. But in this case, I'm having a feeling about the positive pressure, and there could be a fluid misdirection happening behind. There's a reason why the posterior capsule and the bag is seemingly much more anterior than what it should be. So as the emulsification is being done in an anterior plane, which would be reasonably accepted in this complex scenario, I would be concerned about the corneal endothelial health. So after every removal of the fragment, I'm going to inject dispersive OVD first, followed by HPMC underneath. This is what I call a modified soft shell technique, and it does a fairly good job. Now this is the last but one fragment, and as this is being emulsified, let me pause here and demonstrate this stretch line which I am seeing on the posterior capsule. The moment the fragment is touching the posterior capsule, you can see these lines appearing, and this is because the capsule is quite taut and there is some amount of fluid misdirection, which is the reason why the posterior capsule is trying to come anteriorly. So going slow and going anteriorly is the key in such situations. I come out again, re-inject OVD, and this is the last fragment which is being emulsified. Well, the most difficult step of the surgery is finally over. There's hardly any cortex left. I thought this is a time to implant the lens. Now, as I have planned an IOL trap technique, the haptics have to go into the sulcus and the optic in the bag. For this, the most ideal situation would be to remove the capsule hooks now. The capsule hooks are disengaged one by one and they're pulled out of the eye very gently. As I keep telling, for all less experienced surgeon, always keep asking yourselves what can go wrong during this step. So every step can go wrong if there is a drop in concentration levels. So what can go wrong when I'm trying to remove the hook? Well, if you're not very careful, during disengaging itself, you can damage the capsulorhexis margin, and while pulling it out, there is always a risk of causing damage to the colon endothelium, inducing a small descent detachment at the wound, and many more. So be very mindful and ensure that these hooks are pulled out in an automatic manner. The multi-piece lens is loaded into the cartridge, and before implanting, I go in with a sodium hyaluronate, which is a space-forming agent for me. I use it to create space between the iris and the anterior capsule. As it is being done, I can see some amount of retained lens matter is displaced. I thought it's better to address this lens matter now itself. Before placing the lens, go in with my bimanual I&A and take care of this small cortical matter. Back to placing the lens. Again, the OVD is placed over the capsule, and the planned multi-piece lens is now being maneuvered into the sulcus. The first haptic goes in, the second haptic also is dialed in. And before removing the OVD, I prefer to remove this expansion device out. So using a Sensky hook, each of these notches of the hook are disengaged from the pupillary margin, and then using a suture tying forceps, the ring is held and then gently expressed out. So when doing this, because the ring is biplanar, it's likely that it's going to get engaged in the wound or the iris. So using a second instrument like the iris repositor to depress the floor of the incision down is a good trick to pull this ring out. Now time to remove the OVD both in front and behind the lens before achieving this optic capture. Now as it is being done, I feel that the lens is not centering well. I realize that one of the haptic has gone in the bag instead of being in the sulcus. So I go in, dial the haptic out of the bag, and then using a micro forceps, again guide this haptic into the sulcus under the cover of OVD. So now both the haptics are in the sulcus. Again, time to go back and remove all the OVD both in front and behind the lens. It's going to take a couple of minutes for us to patiently remove all the OVD, and once it is done, in this case I also want to do a peripheral iridectomy simply because some of these eyes are vulnerable to develop malignant glaucoma later on. So this PI would help us to differentiate a pupillary block from a malignant glaucoma in the event of an angle closure episode happening post-operatively. So that's the idea of doing this. I want to orient the haptics of the lens in such a way that I can get a good optic capture. So the idea here is we want to place the lens so that the rhexis covers the optic in most quadrants. This is a special situation simply because the CCC is slightly eccentric. So nevertheless, once the entire OVD is purged out of the bag, with my irrigation hand piece in my left hand, the optic is tapped down so that we achieve an optic capture. I just wait for a couple of minutes to ensure that it doesn't get dislodged again. I retract the iris with my Y hook so that I can visualize the ovalization of the rhexis. The haptic is in the sulcus. The optic is behind the intercapsule in the bag, and we can see this ovalization happening at the haptic-optic junction. So now with the lens being secured, it's time to close. Now before closing, I just like to rule out any presence of vitreous in the antechamber. There can be some times when the vitreous can just prolapse through the weak zonules, and thankfully there is none and it looks to be fine. Time to close. So I just don't want the antechamber to shallow, so I want to hydrate the side port and the main incision before coming out through the side ports. And finally, all the side ports are hydrated. Nevertheless, even after long surgery, it's very satisfying simply because our thought process, planning and implementation all fell in line and there are no intraoperative surprises. Well, that can be attributed because of our preparation, I should say, and of course some amount of luck. That's it. Intercam antibiotics are placed. Well, this was the end of a very long procedure. And these are the first day post-op pictures. The patient is doing reasonably well. And these are the post-op OCT pictures. So to summarize, this eye, I had 7 ports. I had multiple devices going into the eye, coming out of the eye, but eventually all is well. So in such complex cases, I think meticulous planning does help. In this case, the smallest detail of ensuring that the anterior capsule staining is done by doing a treat staining before doing the rhexis, or using the CTR at the right stage along with the capsule hooks. All these innocuous looking small steps but when taken at the right time, do have a great impact. Not only during surgery, even they also ensure better post-op outcomes. So thank you for sticking around for such a complex case, which is quite long, and hope you found this helpful.